Okay, this is Cat 3, Cat 3 technique. Hey. So the first thing I'm going to do is prone leg length check. Have my patient prone, checking the medial malleoli for superiority. He has a left short leg, so I'm going to keep that in mind. The next thing is glute fiber analysis. There are points all along the iliac crest in the muscle belly of the glutes that correspond to lumbar segments. So 1, 2, 3, 4, and 5 correlate to 5, 4, 3, 2, 1, respectively. So then the next thing is going to be the indicators. So the short leg should have usually a tight or tender gastroc, hamstrings, glute fibers, and also the temporal sphenoid line up here. So the next thing is going to be SOTO, step out, toe out. It's indicated for sciatica, so you're going to come to the affected leg. I'm going to come over on this side just to show you. So I'm going to take my patient's leg, I'm going to pull it out about 14 inches or until I see the glute muscles bunch. I'm going to externally rotate, hold for 15 seconds, then I'm going to put it back, wait for 2 minutes. I'm going to pick it up, pull it out, turn it, hold again for another 15 seconds, put it back. Then I ask the patient how that felt. And if it got better, then their sciatica is most likely due to a piriformis issue. If it got worse, they most likely have a sequestered disc that's causing, that's pressing on the nerve root. And then if it's the same, it's probably a lumbar subluxation or a disc herniation. So the next thing would be blocking, cat-free blocking, where, so he had a left short leg. Let me grab my blocks here. So it's passive and it's prone. Of course, I ask the patient if they have knee issues. Come up under the short leg side, and I'm going to stick it inferiorly like this underneath the trochanter. And on the other side, it's positioned the same way under the ASIS. So after about 30 seconds to a minute, I'm going to ask the patient if it's getting better. And if it's not, I'm going to start on the short leg side, and I'm going to kind of adjust the block. I can bring it down about 5 to 10 degrees to, whatever point really helps the patient more. And then if that's not really resolving, I'll do the same on the other side. I'll block for maximum of 30 minutes with that. Next thing is block augmentation. So PIFL, I'm going to come to, I'm going to check my patient's internal rotation, and this is going to indicate whether or not he has a tight posterior inferior femoral ligament. So his right side for sure cannot internally rotate as much as the left. So I'm going to come over here to the greater trochanter. I'm going to go 1 inch above and 1 inch posterior. I'm going to have to take a double thumb contact and thrust towards the opposite obturator foramen. Then I'll recheck his feet and make sure that his internal rotation is improved. The next thing I do is lumbar vertebral derotation. So this is going to be a spinous is going one way or the other. I'm going to come to the side that it is. So this is indicated by tender TVPs of the cervicals, which correlate to whatever segment in the lumbars. I'm going to have the patient hold the top of the table in traction with both arms. I'm going to bend the patient's knee up like this as I'm contacting the affected spinous with my thumb, and I'm pushing, correcting the opposite way. So if it's turned this way towards me, I'm pushing this way laterally, and I will hold that for 5 seconds 3 times. The next one is going to be lumbar inferiority. So I'm going to side on this stand on the side where the wedge is inferior. This is a TVP, indicated by a tender spinous in the cervicals. I'm going to have the patient do the same thing again, hold the top of the table and pull as I bring the leg up and contact that TVP or mammillary, and I'm going straight superior with it. And I do that 3 times for 5 seconds each. The next thing is acetabular goading, where and this is indicated by acetabular pain or sciatica. I'm going to bend my patient's knee. I'm going to externally rotate so I can contact the anterior capsule of the acetabulum, and I just am looking for adhesions, kind of working them out, just goading a little bit. I'm going to take him into internal rotation and do the same with the posterior aspect of the capsule. And that should subside any pain or help with some sciatica. Next thing is going to be the orthopedic block. So he's on blocks right now. When he's got a rotated spinous, you're going to take the block out of that side. So if it's rotated towards me, I'll take this one out. His hip will fall down and his spinous will rotate towards the high side that's still up on the block. After that, sciatic traction. So I'm going to have the patient hold on to the head of the table again and pull up with both arms. I'm going to come to the affected leg with sciatica, and I'm just going to pull for 5 seconds and relieve that pressure. And I do this until it's getting better or there's no more improvement, or until it subsides. The next one is assisted sciatic traction, and where I will take a contact with the spinous above the disc lesion to relieve that, and I'll go superiorly while I have a partner coming and pulling on the leg just as I did a second ago. Next thing, sacral base, cough test. So I'll go like this with my hand, and I'll have the patient cough. So in this case, it went superiorly towards the ceiling. That indicates sacral base positive. If it had gone towards his head, it would be sacral base negative, and if it did a combination of the two or didn't move at all, it'd be sacral base neutral. So how to block for that: sacral base positive, negative, neutral under the ASISs. So he was positive. I'm going to go ahead and put that under just like that. And I would leave that there for, while that's there, I'm going to contact the apex since he was sacral base positive, and as he inhales, I will push down on the apex to elicit that movement and come off of it as he exhales. Inhale, push again. We do that 3 times, and that should fix that. Next thing is post-blocking. So after the blocks are out, we're all done. This sitting disc. So if you'll sit up for me and face away from me. Actually, no, face this way because I'm going to come on this side. So this is really good for like disc lesions and like patients that are about to get spinal surgery because their disc is herniated and they're in a lot of pain. This is something that you could do. So you go under the spinous that's above the disc that's affected. I'm going to take an I to S pressure. The patient is going to tuck their chin to their chest and flex all the way forward as I push up. Then I'm going to have the patient extend their back, keeping their chin to their chest, and exhale as I push P to A. And then they'll flex forward again. I'll get that I to S. And so we repeat that until, and that usually works really well for patients with disc problems. Next thing is going to be side posture. So, turn this way to me. We can either do, yes, that's what it is. So it can either be like a spinous rotation or a TVP that's inferior. The rules are you have to have the sciatic leg down. So this would be the affected leg that's down. And when we're doing a spinous rotation, the spinous is also needed to be rotated towards that leg, so down. I'm gonna have his knee, his papillary fossa on my knee here, and turn him this way, contacting the TVP and pushing straight P to A as I traction his shoulder, P to A thrust. What else I would do is, because of TVP inferiority, you want the wedge side, the closed side up, sciatic leg down. So then I will come to the TVP and I'll push straight superiorly on that TVP while tractioning, bring to tension and thrust. And that's all for Cat 3.